Morning, guys. John Adamson, the Rehab and Documentation Guru. Today, I thought I'd read to you a piece of my documentation. I'm going to exclude any HIPAA violating information on the patient, but this is just an example of a summary statement. So, one of the things I try to do, and you can do this obviously a little bit easier in home health when you do case openings and you're reporting to the doctor who sent you the referral, or is going to be your home health attending. You want to provide them a little bit of a synopsis of what's going on with their patient that they referred to you. Now, some people obviously may not have always the time to do this. And my summary statements, which include some assessment, some analysis, sometimes they're short, depending on how busy I am. Sometimes they're long, like the one I'm going to share with you when I have a little bit more time to put a little more detail in there. And I'm going to get a little bit into the discussion about having entry-level doctorates or advanced degrees versus not as advanced degrees to practice. But rather than trying to get doctors to value us more by having degrees, why don't we just show them the knowledge that we have? Why don't we show them that we are a fellow healthcare practitioner to be reckoned with by what we write, what we share with them, the fact that we can show clinical reasoning. Now, will doctors necessarily always read this stuff? No. Let's face it, they're busy, they've got umpteen patients, they see for 5 minutes at a time, they write notes, but maybe one of the nurses will read it, or the medical assistant, or nurse practitioner, or PA might spend a little more time looking at this stuff. But we garner more credibility in our profession from the referral sources. Sorry, guys, I'm like tripping over my own words. By showing them that we've got some meat to our assessment and analysis, and that we expect that they are treating us like a person they've referred to for a consult that's going to give them valuable information back. And so anyway, let me share this note with you. And there probably could be some things I could have done better in this. Dr. Blank, thank you for referring this, and I'll just say he's in his 50s. 50-year-old male with extensive history of PAD, bilateral lower extremities, a nearly blank pack year smoking history. I'm going to just say it that way. This guy had a long pack year smoking history is packs per day times years. That's pack year. And I can't remember exactly off the top of my head, but something like 60 pack years is considered a lot. This guy is well beyond that. History of that smoking, anxiety, multiple bypass of his lower extremities. I screwed that up. And angioplasty, who underwent a right above knee amputation without subsequent rehab approximately blank time ago. So this is a guy that he had an amputation and he spent a few days in the hospital and he just went home and he didn't get anything. Nothing. No post rehab. And anyway, fortunately it didn't end up being that bad off. I was surprised when I saw him. But he's very motivated to get in a prosthesis. Below are my findings as well as recommendations I am requesting you to follow up on. I'm pretty bold about just saying things to the doctor like, this is what's going on, this is what I'd like you to do. And I haven't gotten any pushback. I mean, I try to make sure I'm respectful. Maybe that came out as a little bit pushy, I don't know. Your office will receive orders and a care plan for signature. Timely signature will ensure no delay in the needed services for this gentleman. So I usually put some blurb about that in there. 1. Pain. His right lower extremity phantom pain is moderate to severe throughout the day. He only gets approximately 1 to 1.5 hours of sleep without interruption. One of my goals for this guy was to get an uninterrupted sleep by dealing with his pain. Hopefully it will get there. He has not received any training in mitigating this pain. That's a problem. Both his shoulders are in significant pain, and he demonstrates full range but likely impingement pain with elevation. His shoulders demonstrate atrophy of the bilateral deltoids, and he reports leaning onto his crutches, suggesting potential issue with his axillary nerves, though I addressed how to use crutches safely today to prevent this. So, I'm like showing him I'm doing clinical reasoning, this doctor. Range of motion strength. His residual limb extension and adduction, which are going to be two of the main deficit areas for an above knee amputation, are 5 out of 5, which means he is in good condition to be fit for and start training in the use of an AKA prosthesis. He has not been fit for this and does not have a prosthetist, and that was concerning. Also, his left foot condition is concerning, and bad wording, John. The added pounding on this vascularly compromised and insensate appendage may create further problems down the road. Not a bad assessment, if I say so myself. And then I just wrote who I suggested to look at his leg for prosthesis. I also suggested an orthotic. He's not a diabetic, but he has neuropathy. And neuropathy can cause medial collapse of the arch. And he's pounding on that leg every time he walks without his prosthesis. Mobility. He is independent with the use of crutches, but due to concern of his left lower extremity and high fall risk, should be supervision for outdoors. I got to make it clear this guy's got some issues, definitely, with mobility. ADLs. He is independent with ADLs, but has significant difficulty self-managing meals and any IADLs with bilateral crutches and at the wheelchair level. He also has poor coping skills related to disease, disability, and has concerns over the expense of medications at his income level. I recommend referral for OT for ADLs and behavioral health. We have a behavioral health OT, which is wonderful. And medical social work for community resources. The request for this order will be included in the 485. And then I just kind of wrap up with a, last greeting. Anyway, it's good to let doctors know that you've got some critical thinking behind the evaluation that they refer the patient to you for, and make some suggestions, make some demands nicely in your documentation, because you're trying to show that also to the insurance company, I've identified these problems, I'm going to follow up with them. One of the things I talk about in my documentation course, which if I ever get a chance to present it again, maybe I'll remember what I say in it. But one of the things I talk about is that if you identify a problem and you do nothing to address it, that is called patient neglect. And what I'm pointing out in my documentation, not just for the sake of this doctor, but for the sake of the reviewers that look at this, is I've identified these problems. We're going to do something about it, but it's out of my hands right now. The doctor has to take it from here. And I've done my due diligence. Anyway, it's just a synopsis, assessment, analysis, summary note being sent to the doctor. Do you do that? And if you do, what kinds of things do you include? I'd love to hear your comments and suggestions. Anyway, I hope you have a great day. Take care, and God bless.